So this is going to be the July 2023 MEC Minute, and our topic this month is going to be EMS run documentation. You know, as I look back through the previous MEC Minutes, I really find nothing or very little about EMS run documentation as part of our conversations. I know I've given this talk to various member agencies as they onboard new hires, but as a group, as a system, we really haven't talked much about the EMS documentation. So what are we going to talk about today? We're going to talk about, what is a patient? So, if you're going to talk about documentation, we need to talk about who do we document on. We're also going to talk a little bit about and review about what a run report is. It's not just some documentation of what you did for a patient. It's got multiple functions. We're going to talk some about basic documentation. What are the essential three components of a patient encounter and its documentation? We're going to talk some documentation pitfalls of a patient encounter. And I've got a couple made up sample narratives, some good ones and some that are not so good. And this will be kind of same scenarios, but different ways of describing what you see. So really, when we talk about the patient care report or the documentation of the patient encounter, you got to keep in mind that what you document in your run report is either your best friend or your worst enemy. What you put into the patient run report is going to be archived forever, and it really is the official documentation of the care you provided the patient. I think it's important to remember, that both your chief and I want to cover your back. We want to provide you support. But if there's ever a question about what happened during a patient encounter, we're going to rely on the medical record. We're going to look at the run report. And if you've given us what we need to know to support you, then we can cover your back. If you don't give us what we need to know, or if your documentation is sloppy or is incomplete, then we may not be able to give you the best support that you deserve, or we may be in a position where we have to criticize what you did, or criticize your lack of documentation, lack of appropriate documentation given the scenario. So first off, what is a patient? And this is right out of our clinical standard. So, every patient encounter is going to be documented. We have to determine what is a patient. And, by definition, for us, a patient is any human being that we have face-to-face or eye-to-eye contact with. So if you come face-to-face with a person and you are there because the patient has a complaint that suggests potential injury or illness, or if the patient asks for evaluation, or if the patient has an obvious illness or injury, so the patient may not be able to ask for help, but you look at them and you can see there's a need, or there has been some acute event where any provider or reasonable provider who's awake and functional can determine that there might be an injury or an illness related to this event. And the motor vehicle crashes are probably the easiest example. And then any other circumstance that can be reasonably result of an illness or injury. So, for me, the bottom line is you have face-to-face encounter with somebody who is either directly asked for care, or someone else has made a request on the patient's behalf, or you have reasonable suspicion could have a condition that could be detrimental to the patient. You have an obligation to evaluate the patient and to document. So, keep that in mind. And that sometimes comes into question, mostly with things like MVCs and so on, where was there injury or not? Was there actually a true request for aid, or did some bystander just call and there was no injury? So, really that goes to the next thing is, do I have to do a run report for? Well, here's some of my easy yeses. A lift assist. Yes, you have to do a run report for a lift assist. What does that run report require? It requires a basic patient assessment. It requires basic vital signs, and if indicated, a finger stick blood sugar, and any indication if there is injuries, and if there is any evidence of injury or significant medical issues that you have offered transport and they decline. We have lift assists, and we have examples of lift assists where the engine company goes in, they provide care, they get the patient off the floor, get them off the commode, they do an inadequate assessment, and then the medic's called back an hour later because the patient's hypoglycemic or has evidence of a stroke. And if you go back and look at the original EMS report from the engine company, they didn't provide an appropriate assessment based on the circumstances. Well, do you have to do a run report if the person doesn't want me to evaluate them or deny any illness or injury? And yes, you do have to do a run report. You need to document what you are able to observe, even if the patient won't let you touch them. You need to document what you observe. All EMS and fire providers are trained on situational awareness. I think it's bred into you from the first day of the fire academy. You are very good observing circumstances. So what do you observe during this patient event? And the other circumstances, if you have any doubt, write a report. There's nothing wrong with writing a report. Worst case scenario, it turns out nothing comes of it. But, if a patient comes back 3 days later and said, hey, I had a contact with an EMS provider, they didn't take care of me and I had to go to the hospital, we want to be able to go back to find some documentation of what you did. Do you have to do a run report if you're canceled? If you're canceled by an engine company or law enforcement? No, the EMS providers don't. But if the engine company's one who made the call, the engine company needs to complete some type of a record. If the engine company makes patient contact and provides some type of an assessment, they need to do an EMS run report. If it's something where they get on scene of an auto accident or some other event and patient denies injury, doesn't want care, I think it's okay to document that as part of the NIFRS report. But if there's anything done that could be construed as medical care, the engine company needs to generate a run report. All this is to protect you. We have had episodes where EMS or fire has been on scene, patient has declined care. There is no report done. There's no indication of assessment, even the basics that the providers could observe without touching the patient. And then a couple weeks later, we get a records request from a plaintiff's attorney. So if you have some information, it has to be documented, even if it's simple observations of what you see from 5 feet away from the patient. It needs to be documented. So keep in mind, I understand your pain. Documenting medical care is a pain. I know what you have to do, but I also know what I have to do. I feel your pain. I can spend 5 minutes with a patient and spend 10 minutes documenting the encounter. The documentation requirements are burdensome, but most of it is required. And the other question is, how timely are your run reports? From my perspective, when you go home at the end of your shift, there should not be any outstanding run reports. Again, I understand your pain, but you don't know if there may be a callback the next day or for the same patient. We're going to need to be able to compare notes. And if you're like me, after a full busy shift, patients become a blur. And if I don't document it now, I certainly won't remember one patient from the other in 2 or 3 days on my next shift. So yes, I understand your pain. These reports have to be done on a timely basis. So, what is a run report? Well, the first part is, yes, it is a clinical record. It documents the care we provided a patient. That's the basic part of what a run report, but it's got several other functions. It serves as a means of communication. It is shared with other providers. If it is shared between you as a pre-hospital provider and providers at the hospital or the healthcare center. We have hospital-based internists, our hospitalists, who, when a patient is admitted, particularly patients who are poor to understand, or we really don't understand the course of events, they ask for the EMS run reports. We have cardiologists who look for the EMS rhythm scripts, because if the rhythm script shows an episode of third-degree heart block or ventricular tachycardia, that may allow them to go directly to an intervention rather than have to try to provoke the arrhythmia in other ways. So there are times patients get more timely care, get their pacemaker, get their AICD or whatever, because cardiology can see what's documented by you as providers. It's also a legal document. It's your best friend or worst enemy. It can be used as proceedings for injury claims and so on. And so, keep in mind it's a legal document. The other thing to keep in mind is now in the world of HIPAA, patients have rights of access to their medical records. So unless the patient meets certain strict criteria, like they have a psychiatric illness and the psychiatrist thinks it's inappropriate for them to have access to the records, patients have rights of access to the record. The patients also can request that corrections or changes be made in the record if they think what's documented is incorrect. A simple thing could be, it is a male patient and you call him or her. They may just want to have their pronoun changed. So, I mean, patients have rights of access. They're going to read this stuff, and you never know what comments may come of it. The other thing to keep in mind is if you get subpoenaed on a event, are you going to be embarrassed in court by what you've got documented? So keep in mind it's a legal document. Others have rights of access. It's also an operational document. It records data that may be used to adjust EMS operations. It could be, how many times do we do a certain procedure? How many times do we go to a certain run address that might benefit from a CP evaluation? So it's an operational document. We can pull data out of these electronic patient care records to make decisions about staffing and truck locations and equipment on the trucks and so on. So it is an operational document. It's also a financial record. It's a billing record. All of our agencies bill for medical care provided by EMS, and the level of care that is billed for is based upon what you document. So you could provide high level of care, but if you have nothing really documented, the best your billing company may be able to do is to bill it as a BLS run, even though you provide advanced ALS care. So it has to be documented in order for it to be a billing record. And then finally, it's a compliance document. It really verifies that we and you as EMS providers have met various rules and laws that apply to what we do. So, if we have indication on the record that the patient was intubated by a EMT, that's definitely outside of line of scope of practice, and it's against the rules. But there are all sorts of other things at play that have to do with compliance with appropriate laws and rules, and it could be things like HIPAA. It can have to do with Americans with Disability Act. I mean, all sorts of rules and so on that we can use the medical record to justify what we did or to support the actions we did and to show how we were compliant with the rules that we have to play with. So why do we write a report? Well, it documents our patient assessment. It documents our actions, and it really documents our thought process. And that's really the importance of the narrative. You may say that you started an IV, that you did an EKG, that you gave the patient 2 doses of nitroglycerin, but we need the narrative to fill in the details. It's a very important component of what we do. It explains why we did or didn't do something. We have our EMS protocols, and they are guidelines. I know you're bored and tired of me hearing this, but we can't protocolize every potential scenario that you have in the field. So sometimes you have to make clinical decisions and provide care that are not specifically covered by the protocol, and you have to use your clinical judgment and experience to make a treatment decision. The narrative is where you explain why you did that. That's where I will go. That's where others will go to see why you did this and not that. So, if you're going to do anything that looks like a protocol variance, use the narrative to explain your thoughts. And then the narrative also serves the chart serves as a means of communication, and it provides continuity of care. Like I mentioned with our hospitalists, they like to see what's going on with the patient. We have patient databases at the hospitals having to do with stroke, STEMI, and trauma. A lot of what we have to enter into our disease databases comes off the EMS medical record. If you provide a 12-lead ECG in the field and we have documentation of receiving it at the hospital, we get credit for door to ECG of 0 minutes. Our goal at the hospital is less than 10. EMS ECGs give us 0 minutes. It really helps our data. And finally, what about the documentation basics? Really, if you look at what we do with the medical record run report, there are 3 things that we need to cover, or that it covers for the viewer. It says what you observed and measured. So the patient was dyspneic, their pulse oximetry was 90%. What did you do about what you observed and measured? Patient was hypoxic. I started them on oxygen. I gave them a dose of bronchodilators. And then what happened after you did it? I gave the patient bronchodilators. They got better. So really, if you look at the medical record, there are 3 basic components of what goes into it, even though we have it broken down into, vital signs, chief complaint, or dispatch code, things like that. And then finally, just about the basics, make sure you read your report before you submit it, because others are going to read it too. So, the report, it's well written. A thorough run report suggests a thorough, efficient assessment and quality of care. A sloppy report, one that's got poor grammar, poor spelling, uh, one that doesn't read well, incomplete report suggests sloppy, inefficient care. You know, um, what we see is what we believe. So if we look at a run report and it's all sloppy, it doesn't look good, then many of us will think, well, did this provider really know what they're doing to provide effective care? So, well-written report suggests that you did a good job. Sloppy, incomplete records suggest inefficient care. Effective reports, they're completely objective. Keep in mind, we all have opinions, we all have personal values, but our run reports should document observations rather than assumptions. We should avoid terms and words that are emotionally charged or have some discriminatory value loaded into them. We need to be direct in what we observe. We shouldn't add editorials and opinions. Editorial comments can come back to hurt you. The effective reports also have documentation that's based on physical findings and direct observations, and then things that are legally relevant and in compliance with established standards of care. So, these are things you need to consider when you are writing the reports. Well, how about basic documentation? How do we approach this? So, basic documentation should be legible. Well, with our electronic patient care reports, they should be legible unless you have your fingers on the wrong keys of the typewriter or the keyboard and you don't read what you did. So legibility for us shouldn't be a problem. Misspelled words, we should try to avoid them. Think about spell check, but we should try to avoid misspelled words. Use approved abbreviations. If you have personal abbreviations that mean something to you but are not generally recognized as medical abbreviations, please don't use them. I've seen some EMS protocols where there's actually a listing of approved abbreviations as part of the protocol, and those are the only abbreviations you can use. Your report should be succinct with appropriate details. I've read some reports where the narrative is 3 or 4 paragraphs long, and I still have no idea what was done for the patient. I look at run reports where the narrative is 3 to 5 sentences long, and everything is covered. I know exactly what happened and how the patient responded to care. Keep your reports factual and not editorial. We don't need to get into departmental issues in the run report that may come back to embarrass you or the department or could serve as reasons for liability. So nobody needs to know that you're short-staffed today. You provided a response, you provided the care with the resources that you had available. Try to keep your times accurate. I kind of cringe when I see a comment that all times are approximate. Do the best you can when you're documenting your times, and that's particularly true for times that you're on scene, times that you provide interventions, and so on. Make sure you document vital signs, treatment, and medications. I will get back to vital signs in the next slide. Make sure your documentation shows actions that are consistent with the protocol. If there is a narrative, if there is a variance in terms of your actions versus the protocol, please make sure you explain it as part of the narrative. Again, I realize that we can't protocolize everything, and you may have to use clinical judgment to make a treatment decision. Please just explain it. It doesn't need to be a big, long explanation. Just something to indicate what your thought process was. And another thing, just make sure that your narrative matches the other documentation. One of the downsides to our electronic patient care reports is you can just blow in a bunch of normals as part of your physical assessment, even though you don't even evaluate that part. Patient has an ankle injury and you document that breath sounds are clear. Did you really listen to the chest? But also make sure your narrative is in line with your documentation. The documentation may say, right leg is normal, and you look at the narrative says, you call on scene, patient suffered a fall, and now they have an ankle that's deformed and angulated laterally. Well, the narrative doesn't match what you've got documented as your physical exam. So make sure there's no inconsistencies there. I think in many cases, if you didn't do it, don't document it as being normal because you didn't check it. If you didn't listen to the lung sounds, don't say that they're clear. And remember, keep in mind, others we're going to, including the patient, may read your run report. So make sure your documentation is correct. So I alluded to vital signs. Okay, we've got the original 4. Blood pressure, pulse, respiratory rate, and temperature. But I have 6 additional items that I consider also vital signs, which may or may not be applicable based on the patient condition. Pulse oximetry to me has quickly become the 5th vital sign. I think most of our patient encounters include that. It's almost automatic. GCS is mandatory for all trauma patients. I think we have our record set up so if you have an injury-related complaint or a trauma-related complaint, you can't close out the record unless you have a GCS document. GCS is important. It is also important in terms of our transport decisions. Patients with an altered GCS may have to be transported to the trauma center based on the state trauma triage criteria. So GCS is important. Pain scale is important if it's applicable, and we really need to have it before and after treatment. Patients got a pain score of 10 out of 10 because their ankle is angulated and fractured. You give them fentanyl or ketamine, you reassess their pain, it's now 4. So pain scale is important. Finger stick blood sugar, to me, it's a very important thing for anybody with altered level consciousness or symptoms hypoglycemia. It should be checked before and after the D10. Capnography is important, and keep in mind it is now mandatory. It is mandatory from the Division of EMS for any patient with advanced airways. So intubated, iGel, CPAP or BiPAP, they have to be on capnography during that treatment. And then the last vital sign for me is the Lamb score for potential stroke patients. So the basic 4, pulse oximetry is probably another one, and use the others if you need it. I think, for us, we should also look at frequency of vital signs. I really think we should have at least 2 sets on any patient who's transported, one at the time of assessment, one as you're pulling onto the hospital campus, and others in between as you need it. There are many times, not many, there are times, I hear that the patient arrested on the ramp or the EAD is upset because the patient was unstable, whereas if you look at serial vital signs in the truck, the patient was not unstable. They did acutely deteriorate shortly after arrival, and that does happen. All right, special documentation considerations. Non-transports are your greatest potential liability. For me, my greatest potential liability is the patient I discharged from the hospital. For you, your greatest liability is the patient you don't transport. So make sure you have great documentation. From my perspective, patient refusals are high risk and often overused. And as part of our documentation, we have to indicate the patient's got the correct state of mind. In other words, they have the capacity to refuse, and the patient's refusal must be informed. If the patient is going to be signed off as a refusal, then you must document that they've got the capacity to make an informed decision, meaning they understand the risks of refusing care. And we should also, as part of that, explain why the care is necessary and inform the patients the risk, like I mentioned. We can use a refusal checklist, which is on the next slide. And I also want to caution or talk about, we have some patients that truly refuse versus we have some patients where the EMS provider makes a determination that transport is not indicated and does not offer transport. Patient's got a minor scrape on their toe, you put a Band-Aid on it, they don't need transport. So if you elect to not offer transport, that's a non-transport, it's not a refusal. We should not ask patients to sign a refusal if we are not offering transport. For me, a refusal is a patient who has a need for transport or you think they need to be transported. They do not want to go. That's a refusal. They sign the refusal form. Here's kind of the refusal checklist. It's in the protocol. Basically you can review it. We have different things to look at. Patients who are clinically unstable, patients who are minor, patients who lack capacity, those patients should be transported. I'll let you review that as part of the protocol review. Let's talk a little bit about the art of the narrative. Not looking for Shakespearean prose here, but we're looking for something that reads relatively well. The narrative outlines your thought process, including why you did or did not do something. So if you felt that you needed to do something, a little variation, just explain it. The narrative should justify your actions. You gave the patient IV narcotic because of pain and because you see that they've got an angulated fracture and they're extremely uncomfortable. The narrative fills in the blanks. It fills in those things that we can't cover by way of the physical assessment or vital signs. So it fills in the blank. Make sure the narrative matches the exam and procedures documented elsewhere in the report. Again, your 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 blow-in physical assessment says the right leg is normal. Your narrative says there's a deformed right ankle. Avoid abbreviations that are not universal. We don't have a glossary of approved abbreviations, although each department may. I'm not aware of any. Whether or not you use chart or SOAP versus just some free-form writing of the narrative, I leave that to you. I was trained SOAP years ago, which is subjective, objective assessment and plan. And even though I don't always put SOAP as part of my documentation, it runs through my head as I dictate my medical decision-making component of my medical record. So use what works for you. You don't need to explain your decisions in terms of which you pick. But if chart helps you format your process, feel free to use it. Same thing with SOAP. Some pitfalls. No vital signs or unable to obtain vital signs or one set of vital signs on the chart. From my perspective, no vital signs or unable to obtain is different than saying the patient has no pulse, the patient has no blood pressure. But to be unable to obtain means you didn't really try very hard, or the patient wouldn't let you touch them. No blood sugar or ECG when clinically indicated. In our patient population, you cannot be accused of doing too many blood sugars or too many 12 leads. If you think they need to be done, do it. You never know what you may find. You have a patient with epigastric abdominal pain, just doesn't look right to you. Do a 12 lead. He or she may have an inferior MI giving him epigastric pain. So if you have a suspicion, do it. From my perspective, if you think about doing a blood sugar or doing a 12 lead, then just do it. Something in your head is saying, hey, this patient may have an issue there. Another pitfall is inadequate assessment based on the patient complaint. Going back to EKGs, patients having chest pain, maybe it's sharp, but they have a chest pain, you don't do an EKG. That's not an adequate assessment. You don't listen to their breath sounds to see if they have any evidence of pneumothorax. So you have to make sure you have an assessment completed and make sure it's appropriate for the presenting complaint. Again, I'm beating this one up, but documentation does not match the narrative. Another thing is if you do a 12 lead or a 4 lead, what's your interpretation? Normal sinus rhythm with PVCs, whatever your interpretation is. And then the last thing as a documentation pitfall is failure to document reason for protocol variance. I understand and accept that you may need to make a variance from the protocol. If you do, please document your reason why. Okay? So just a couple quick example narratives. Same patient. So the first version of the narrative is, patients found down on arrival, sitting on a curb. And these are going to be quotes from the narrative. Patient is filthy, smells of BO, pissed himself, he's obnoxious and acting like a dick. Obviously drunk, no visible injury. Patient released a police officer on the scene. So that's one narrative. I think most of us agree it's not a great narrative. Second narrative is the same patient. Patient or dispatch for patient down. Patient sitting on curb and denies discomfort or injury, appears disheveled and incontinent of urine. So those are observations, they're not opinions. He's agitated but able to verbally de-escalate, admits to alcohol, vital signs is documented and normal. GCS is 15, blood sugar is 90. No active vomiting, exam is negative for head, neck, or extremity injury. I put that in there because we have a protocol and clearance on release to the police, and this covers a lot of those points. Transport offered, but patient declined. On further assessment, he has a capacity to refuse care. Patient released to police officer on the scene. So if this was your patient and 3 days later you get called from the chief's office, which narrative would you prefer? I think it's pretty easy there. So just some examples of the narrative issue. Another one here. Arrived on scene for a single vehicle MVC on freeway. On arrival, everyone refused care, medic, and service. Okay, and this is a common one. Arrived on scene for a single vehicle MVC on a freeway. On arrival, vehicle into guardrail with moderate damage to the driver's side of vehicle. No airbag deployment. 4 occupants, all out of the vehicle, all denied injury and declined evaluation by EMS responders. All occupants ambulatory and alert without obvious physical impairment or visible injuries. Second offer of EMS evaluation declined by all 4 occupants. Medic and service. Occupants advised to call back or go to ED if they change their mind. Again, which one would you rather get called in on? Like I mentioned before, if the patient or patients refuse an assessment, document what you can observe. It's going to help you if something happens. We have had over the 10 or 12 years I've been with MEC, we've had a couple episodes where we've had injuries or we've had auto accidents on freeway. People have declined injury, and a day or two later they die from an undiagnosed or unrecognized injury. And it's documentation that makes a difference in terms of, did we provide an adequate assessment or not? Keep in mind, as EMS providers, we have tremendous liability protection from the state as long as there's no willful or wanton neglect or actions. I think you could easily say that the first narrative would suggest you didn't document enough, and if there's a bad issue, you're not going to have protection, and you may not, or you may be found not to be eligible for that immunity. Whereas the second one covers your tail. So keep in mind what you document is important. And I think my last one is, patient SOB with oxygen 95, no edema, right AD, IV, intubated with $1.8 tube, responded to the ER. Well, this one I just made up. I actually made all of them up. I think most of us go nuts when somebody documents with all caps or gets an email with all caps. So the formatting is off, multiple spelling errors, and really no punctuation. Second one, same patient with dyspnea and O2 sat of 95%, no edema, right AC IV, intubated with number 8 endotracheal tube, responded to ER. So two different examples, but this one is not far off from some of those that I've seen over the years. So that's my quick review of documentation. If you have any questions, please post them on Basecamp. If you have any what ifs or questions about how something might be documented, please post it on Basecamp, and I'll respond for everybody to review. Thank you.